So, at the outset, I'd like to thank Dr. Jayanta sir for having me in his course. Yeah. So, I'll just briefly be covering congenital epiphora, and basically CNLDO is the topic. So, when you have a child with epiphora, you mainly evaluate the child starting from the puncta till the nose. And what we'll be mainly talking about is how to manage congenital nasolacrimal duct obstruction. Now, all of us know the basic anatomy, and this is the diagram that we all sort of work with. I think this is stuck. थोड़ा freeze हो गया है शायद. Yeah, okay. And starting from the punctum, it's important to know where the punctum starts, where the canaliculus starts, where it ends, where you can expect a hard stop, a soft stop, and where the meatus opens, the middle meatus and the inferior meatus, because these are important landmarks when it comes to evaluation and management. Now, with respect to the watering eye, it could be either hyperlacrimation or epiphora, as we are planning to discuss in this instruction course. So with evaluation, it's not only the meticulous history taking, but also a good external examination and diagnostic tests, and when required, for example, in traumatic cases, you need imaging. Now, in the history, when there is watering in general in a child, you need to know, is it unilateral or bilateral? Is it constantly overflowing or intermittently watering? And is there any seasonal variation which could indicate that there is an allergic component? Other than that, the type of discharge would also indicate if there is any pain and swelling involved, if there are any nasal symptoms, and various other symptoms which would indicate corneal issues or uveitic conditions. Now, with respect to the past history, is there any previous attack of adnexal inflammation or infection, any sinus disease or ENT pathology which needs to be treated before we treat the CNLDO, any trauma, and any surgery done in the past? Along with this, any topical medications that they are on, also it's helpful to know. Now, with examination, the external examination includes also the nasal examination and the diagnostic and secretory tests, which I'll be coming to. So, for example, if you have a child like this, this is a condition called dacrocele, and it most commonly results in a respiratory obstruction. So it necessitates a surgical intervention before you go into any imaging, and it happens at a very young age. And the most important thing that we check in our OPDs before we even go into the syringing is the ROPLAS, or regurgitation on pressure over the lacrimal sac. I'm sure we all know how to do this, and this is the most commonly done. Now, in a child, doing a fluorescein dye disappearance test is extremely helpful because they are not cooperative usually for a syringing unless they are older children. So doing a fluorescein dye disappearance, especially doing it in both eyes, helps you see the difference between both eyes. In one eye, there would be some retained dye even after 5 minutes if there's a nasolacrimal duct obstruction. So with respect to probing, so before you go into the syringing, the probing interpretation is again very important. Like I mentioned, knowing the anatomy helps you know where the hard stop would be and where the soft stop would be. For example, here you can see at the common canaliculus, if there is an obstruction, you get a soft stop. The probe doesn't go and touch the bone. Now for syringing, syringing has some important findings that we need to interpret. So if there is clear fluid from the opposite punctum, it could be a common canalicular block or a nasolacrimal duct obstruction. But if there is definitely mucoid fluid, it's the nasolacrimal duct obstruction. If it is partially patent, it's a partial obstruction. If it is patent but there is epiphora and sac dilation, it could be an atonic sac, which is actually there in older people. And regurgitation of clear fluid from the same punctum indicates a canalicular block. And mucoid from the lower punctum, when you do through the lower punctum itself, could be a NLDO with a upper canalicular block. So it's important that you make sure you know where the stop is happening, what the nature of the fluid is, and whether it is coming from the same or the opposite punctum. Now, with respect to congenital nasolacrimal duct obstruction, probability of spontaneous resolution up to 12 months of age is quite high. And after 12 months of age, it keeps reducing gradually. So it's important that we target these patients right at the beginning within the first year of age. Now, management can be conservative or surgical. Conservative, as we all know, is the hydrostatic massage. But how the massage is performed is actually very key in these patients resolving spontaneously. So it's important that you mention to the patient that it is a hydrostatic massage, which means you need to apply pressure at the medial canthus. Not only that, it has to be done repeatedly. So at least 10 times, 10 strokes to 15 strokes, around 3 to 4 times a day, and that would be the best way to open up the membranous obstruction. Now, the age for surgical intervention is, of course, after 1 year. And till when do we do probing is again a debatable topic, because people have attempted probing even in the teen ages, so even at 13, 14 years of age. And first line of treatment after the Krigler massage doesn't work is, of course, probing with irrigation. The second, if the probing with irrigation fails, then you do a repeat probing and with a silicone intubation. So when do you probe? Again, this is after 4 months of age, and 4 to 8 years is considered delayed in the older times, but not so much now, because a probing can be successful even in older children. So the technique, of course, is the nasal packing. A technique for the passage of the probe, I will be demonstrating that also in a video, and the confirmation of the patency. So it's done under general anesthesia. A syringing is first performed to check the canaliculus also. And you go ahead from the upper punctum, go downwards, backwards, and laterally. So success rates, again, for probing keeps reducing with age. So if it's done earlier, it is better. And the first probing has, of course, a higher success rate than the second probing. So immediately after the procedure, it's important that you advise that the patient gets some kind of nasal decongestant and nasal steroid sprays, steroid antibiotic drops. And along with that, as far as possible, tell the parents to avoid anything which might trigger an allergic reaction or a cold or cough in the child. Complications of this include bleeding, a false passage, inability to pass the probe down later, entry into the submucosa of the lateral wall. Basically, any type of false passage can take place, and after failed probing, you may get a bony obstruction later with age. Now, how do you manage a failed probing? Like I mentioned, the repeat probing and the intubation. Now, when there is an inferior turbinate which is obstructing the inferior meatal opening, you need to do an inferior turbinate infracture, wherein you go in with the periosteal elevator and you sort of medialize the inferior turbinate to create that space for the opening to come up. So you can see this periosteal elevator here, and once you get a good space to put your periosteal elevator at the inferior turbinate, you go in and medialize it. Now, you confirm the patency by blocking the other punctum, and then you put the syringing through the other punctum. Now, with respect to intubation, you can have a monocanalicular intubation or a bicanalicular intubation. The bicanalicular is usually preferred, such as the Rittling. And they are similar with their success rate. However, personally, I prefer the bicanalicular. We can discuss later what experiences everybody has. And again, it is done when there is failed probing, or it's preferred to be done along with the DCR when it's done in older children. So some of the complications are that you could have extrusion of the tube as well later on, but that's less common with bicanalicular intubation. Now, balloon dacryoplasty, not performed by us that much anymore, but the basic thing is that you go in, keep the probe along with the balloon inside the area with the suspected blockage, and you inflate and deflate in these timings the balloon, and later on you would find that the opening is patent. The other thing you could do is a nasoendoscopy assisted probing. That is where you visualize the lower end of the nasolacrimal duct, like how you can see beyond this inferior turbinate, and you can see that the probe is coming through. If you don't have an endoscope, you can just do a metal on metal contact with the probe touching the periosteal elevator. Now, of course, DCR is done after the age of 4 years. I think it will be discussed, this will be discussed anyway. And newer modalities are dacryoendoscopy. And the recent opinions, like I mentioned earlier, was that people are trying to do primary probing in children even between 8 to 12 years of age before offering the DCR surgery. So this is a rough outline of how you would generally manage a case of congenital nasolacrimal duct obstruction. And thank you.
Almost cover almost all everything A to Z. But there are just few points you are mentioning. To the patient, I just mentioned after the word lacrimal sac pressure. Just
right.
Modify.
Hydrostatic.
Moment you can tell the massage, they will do along with the servant and grandmother and everyone is touching this part. So it's a very small 8 to 10 mm or maybe in pediatric 8 mm. So is it basically pressure? With that finger is pressure is enough. Just instruct the parents to demonstrate first. Those are the punctum area. You should close the punctum or canaliculus. Common canaliculus is very difficult, but you can close the punctum. Moment if you are safe to close the punctums, but parents are very happy if there is a Roplus is positive. Their thought is comes out. This is a wrong. To create the hydrostatic pressure, it should be inside.